Hello and welcome to Unstress. My name is Dr. Ron Ehrlich. I'd like to acknowledge the traditional custodians of the land on which I am recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders, past, present, and emerging. Well, today we are going to be exploring the world of allergies, and it is a big topic. It is one that when you hear it, you'll be amazed that we don't all suffer from allergies. And it may surprise you that 20% of the population do officially, but it's a testament to the human body that we don't all when you consider some of the factors involved in it. So my guest today is Professor Pete Smith. Now, Pete is one of Australia's leading allergists. Pete commenced his medical studies at the University of Tasmania and went on to specialise in paediatrics in Adelaide before completing a PhD in molecular immunology. He's worked in London. He has his clinic in Queensland, in the Gold Coast, where he provides patients literally with the highest level of quality medical care in the diagnosis and treatment of allergies. And again, I'm bringing to you, Pete has a clinic in the Gold Coast in Queensland, in Southport, where he provides patients with the highest level of quality medical care in the diagnosis and treatment of allergies. He takes holistic to a whole other level, and it's a real treat to hear him just piece it all together. He's also professor in clinical medicine at Griffith University and Bond University, and he currently conducts research studies in the molecular aspects of pain in allergic conditions. He's an active member of the Australian Society of Clinical Immunology and Allergy and a regular expert commentator in the media, and you will see why. I hope you enjoyed this conversation I had with Professor Pete Smith. Welcome to the show, Pete.
Thanks very much, Ron. Pleasure to be here.
Pete, I've been looking forward to speaking to you for some time now, and you've got an incredible background. Can you just give us a little bit of your journey that's taken you to this point professionally?
Yeah, look, I guess I was grew up as a kid seeing doctors as a esteemed person in a community, somebody that could look after people, could change people's lives. So that was aspirational, I guess, from even about 10 years of age. So it was a pursuit there. I did university, and part of that, I enjoyed the aspect of paediatrics in that we could make people better. It wasn't part of stopping the decline, which a lot of healthcare is, and band-aids as people just slow their decline. Kids got better, bounced back, and somewhat self-rewarding. I found that as an area of interest. When pursuing that as a specialist, I became very aware that allergy and immunology just clicked with me. The molecules, the mechanisms seemed to make sense, and at that stage, in the very early 90s, it was looking like immunodeficiencies, which again took me back to holding people together as they died, or HIV medicine. So allergy was something that was really only starting to be defined at that time. I'm talking about nearly 30 years ago when I was making those choices. And that was still the stage where we were relying on books and journals and publications and libraries and faxes to get information. And IgE as a molecule was only really defined in 1966-67 by the Japanese and Swedish researchers. It was
IgE, immunoglobulin E.
It was the latest one to be picked up because it only represents 0.1% of our total immunoglobulins that we make. So it's there in very small amounts, but when it goes awry, it can really define severe phenotypes and diseases in people. So linking that to journal papers, linking that to studies, and then to textbooks to practice really was a deficiency, and still remains a deficiency because of relatively fixed curriculums. Curriculums aren't fluid. They tend to be what works, and we'll do that again. So to get something new in curriculum takes a massive shift and change, and it gets largely based by the specialists you have in hospitals. And allergy is something that doesn't keep people in hospitals, so hence Australia didn't have the passion to have large hospital allergy departments. And it crosses several disciplines. It actually crosses respiratory, skin, it crosses gastrointestinal, and as well as emergency with anaphylaxis. So existing departments sort of dabbled in it and claimed a space. Kind of a bit of a battle like hand injuries, where they belong to orthopedics, plastic surgeons, specialised microvascular people, or neurosurgery for nerve surgery with hand injuries. There's a lot of argument where that is. So allergies didn't really define a space, and hospitals were already having the fight for existing services. So we didn't see the growth like we did in the US, where allergy departments were set up. Again, probably because in large clinics like the Mayo or Cedars-Sinai, they were actually seen as an outpatient service that would actually bring revenue to the hospital. So again, the government system didn't see that develop. So going back to the early 90s, we could solve problems, and it really improved people's quality of life by addressing allergies and identifying. So great detective hunt. And so I did my PhD in molecular immunology, and then went over to the United Kingdom. I had the privilege and honour to work as a consultant there at Great Ormond Street, and I used to run their food allergy clinic between 1999 and 2001. So I was there for 3 years, and I was getting to that stage in my sort of late 30s and making a decision of whether I should come back to Australia or whether I'd end up being in the UK all the time. And it was a pretty easy choice to want to come back to Australia. I had family here, so I made the choice to come back, and I set up in Queensland and have a practice here on the Gold Coast. I was in Brisbane working with an adult colleague for a couple of years, and now I see both adults and kids, and I have a GP-based practice called Allergy Medical in Brisbane, which I supervise. I attend there once a fortnight. We discuss cases regularly, virtually every day, with the doctors there, because a lot of allergy care can be done at a good primary care level if they have the time and the resources and the backup as well, and the protocols. So,
Tell me, I mean, we're going to obviously talk about allergies, but I wondered if we could just give us Allergy 101. What is it, and how common is it?
Okay, it depends what form of allergy we have. If we're talking about things like hay fever, allergic rhinitis, but probably about 20% of Australians have it. We see it a lot in young children, adolescents, early adult life. And allergy, going back a step, is an abnormal response to a perceived threat. So, dust mites and grasses and peanuts are really not that dangerous, but our immune system gets it wrong. And you're going to ask why, and that's going to be a multi-layered answer as well. But we see allergic rhinitis maybe 20-25%, a significant amount of asthma. Australia has one of the highest rates of asthma in the world. At least 80% of childhood asthma, there's allergies involved. Probably a good 50% of adult asthma will have an allergic layer. We have food allergies, which occur in 5 to 8% of children. We have eczema, where again a significant amount of eczema can be driven by allergens as well. People question, can they or can't they? That's been proven in allergen chambers, where they put it through the air conditioning to look at the treatment for rhinitis, and they'll see that people's skin will flare up a day or so later after that allergen exposure. So we know that they can flare that up, and there's been a series of double-blind challenges with foods and seen eczema flare up with and without those foods.
Because that must be one of the challenges is people associate allergy with, I've come in contact with something, I've started to sneeze, I've got a rash, it's an immediate response, but sometimes it can take a little bit longer. And that's where the detective work, I guess, really creeps in.
It is. Some of these can be summative effects, like you're talking about people getting hives. We can get rashes. We can get contact dermatitis, which is a type 4 reaction, which will say somebody might walk past a grevillea and start to get itching 10 hours to 2 days later, which will flare up for up to 2 weeks. You think, what on earth have I done? And it'll just be at that site and can be very aggressive. So there's a contact dermatitis, or where somebody's undies are wearing a bit thin, the latex can cause a latex rash. Or colophony, a very common adhesive that we will use on Band-Aids, and people get a rash there that will last for 2 weeks. But we get colophony in Pears transparent soap, or if you get pine sap on you, it's an extract from pine tree. Metal allergies tend to be that backs of watches, jewelry. Nickel's a very common contact allergen. Hives can come up because our bodies fighting something that it thinks is a danger, and that can be very exuberant. But it can also be a case where we make a mistake with ourselves. We've found that many patients with chronic urticaria, where they get hives all the time, day and out, for months and times years, actually make IgE allergic antibodies to themselves. They're actually allergic to themselves, which is sort of a bit of a revelation, but that's only really come to the forefront in the last few years. But that'll flare up again with a layer cake. So if people are stressed, poor sleep, these type of things can make hives get worse. Like pain, if we have poor sleep, pain scores can increase by 30%. If we have poor sleep, itch scores go up. If we eat foods that are high in chemicals, between 30 and 70% of patients with hives will become worse. So while those are cofactors, it's important to know about them, and they give us great opportunities to improve the condition until there's not a threat going on by getting those right. And that's part of the joy of unravelling that, and also communicating that to our patients.
Yeah, and yet Australia, you mentioned Australia has got one of the highest rates of allergy and asthma.
Yes.
Yeah, and why is that so?
I'd say that it's a land of plenty and probably good self-indulgence. We've got, and this is purely speculative, as far as the Western world goes, we and the UK and the US all look pretty similar. We have taken on ultra convenience of fast foods, ultra convenience of being indoors, watching TV, not exercising. I certainly have published on how we have more advanced glycation end products, which are products that form when you cook sugars at high temperatures or super high temperatures. They look like compounds that our body's never seen before, but they mimic and look identical to compounds that are released from damaged tissue. So these are called advanced glycation end products. So advanced glycation end products look very much like alarmins, which are a particular one called HMGB1, the high molecular group box 1 protein, that gets released from damaged tissue and tells the body, hey, we're in danger. And that can cause mast cells to degranulate. It can cause nerves to be sensitive. It can put cells on high alert and to be protective. So allergy is probably self-protection gone wrong. And when we have repeated stimuli, we have amplification of disease process. We have lots of things that interfere with our homeostasis. If we're looking at food allergy, we've got our ideal homeostasis eating a wide range of natural foods, less sugar. We know that fructose, a human can't take more than 4 to 6 grams of fructose at one time, and that's with fibre. That's with all its natural flavonoids and antioxidants that go with it. You juice it, they will disappear, and you have an overload even though it's healthy. So we're having a lot more sugars as well, which can form these compounds. We're cooking at microwaves and frying stuff, so the human body hasn't seen food prepared in that manner before, and it mimics that. We've got irritants in the airways, pollutions. We know diesel exhaust particles plus allergens can amplify an allergic response and promote an allergic response. We're seeing microplastics appear in our airways, in our food, even in our bloodstreams. So they will cause irritation. We need our bacteria reflect what we eat. So bacterial diversity, the types of things we put into our diet. We have inflammation that occurs after we eat a meal. And I know you'll be very aware of the oral microbiome, and that's certainly somewhere that hasn't been really explored in food allergy. Most of the focus has been on the gut and the talk that goes between there, but we'll touch base on that as well. Hopefully.
Yeah, no, please do. I mean, yeah, the oral microbiome in terms of, talk to us about that.
So, well, place where foods get seen very, very quickly, and we rely on an intact epithelium there, and sensation. So the mouth is very highly innervated and has got lymphoid tissue in the tonsils there to sort of recognise and react. And we use that route to desensitise people, say, with sublingual immunotherapy. But very little has been studied on the oral microbiome compared to the gut microbiome. The more we eat the better diverse diet, eating the rainbow, eating leafy green vegetables, you get a preferable gut microbiome. There are some herbs and plants that particularly improve that. We know that eating rubbish food, surprisingly, can make it worse. Antibiotics, antacids can change that around and ruin some of our own defences.
And another area that we focus on a lot is mouth breathing and nasal breathing, and that's got to set us up for allergies just there alone, being a predominant mouth breather, and it's so common.
I'll get back to that, but I'll take this back one step back further about the mechanisms, because our bacteria has to communicate. We've got quorum sensing receptors that pick up danger, and we've got a range of compounds in processed food. We've got emulsifiers. We've got detergents that are left on plates even after washing them. 1 part per million can interfere with the bacteria talking to the gut lining. We need to have bacteria to tell us that we're alive. In sterile animals, studies done in the Lancet in 1966, it was rabbits brought up in a sterile environment, basically developed anaphylaxis with feeding. Pseudo has, a Japanese study, have shown similar with mice born in sterile environments drift towards allergic responses. But we need our bacteria to tell us things are okay. And we have a barrier with emulsifiers, things that make our butter smooth better, that make our toothpastes work better. And you see where I'm going with this. So ice cream scoops better. So we have emulsifiers, carrageenan, which creates a film, a surfactant, and we have surfactants, detergents that actually stop the bacteria talking to the lining. And hence, animal models, it looks like that's very important. What's the point of having good gut microbiome if we're not getting able to talk to the epithelium and the immune system beyond that?
Gosh, you talk about cooking methods as setting us up for compounds that we're not familiar with, but the number of chemicals that are going on in our world is just growing exponentially. It's actually, when you talk about all these things, Pete, I'm amazed. I was shocked initially. 20%, wow, that's a huge number. But when you talk about all the things that contribute to it, you think, how on earth? We must all be allergic to some degree.
Yeah, well,
it's a question whether it's clinical or subclinical.
Yeah, we're resilient. It's amazing we're still here, but
yeah.
Look, that's a whole different. I'm hesitant to use the word ball game, but male fertility was shown sperm counts have dropped by 50% in the last 40 years. So something's going wrong there. So something's in the water, and our bodies are saying it's not right. So going back to the oral microbiome, we're sort of seeing reflux disease. Barry Marshall, as you're aware, identified Helicobacter as a factor, and there's this passion to turn off stomach acid because we can. Stomach acid is important in breaking down food proteins. In animal models, it's very hard to create an animal model of food allergy without turning off the stomach acid.
Interesting.
We've got very good at doing that in the last 30 years.
Yes.
But also, in the last 30 years, our fructose consumption's gone up by 70%, 700%.
What?
So, it's a cheap flavouring, and that very much parallels our rise in food allergy in young children. It's a great superimposed graph. So eating clean would seem a very sensible idea.
Yes. Well, I know that antacids is a multi-billion-dollar industry, and I think when you factor those in with over-the-counter ones with the prescription ones, it's setting us up for, you said, without without a stomach acid, we're less susceptible to allergies. So here we are trying to switch it off all the time.
It's a bit circular as well. These drugs were approved for short-term use for acid suppression. We certainly don't want acid spilling up and causing what we call Barrett's esophagus, where we can get chronic erosions and cancerous change with reflux. And up until the 90s, we're doing operations on these patients. But we give long-term acid suppression. We can get micronutrient depletion. We need acid to digest. We also see we affect our microbiome. We get depleting magnesium And magnesium and melatonin are two of the most common endogenous compounds that actually tighten lower esophageal tone. And so
Interesting.
you'll actually set yourself up for reflux by treating your acid suppression.
Right.
The Canadian Gastroenterology Association has talked about osteopenia when you're using these products more than several years. We do have metaplastic change. We will see more enterochromaffin cells appear in the stomach after years of using these proton pump inhibitors. And safety of these really has not, long-term safety hasn't really been established in children where they get used, and certainly not in under 2 years of age, where they, if you scream, you get reflux. I think we're going to see a revolution in tied against them as there's more and more evidence of their potential side effects, like we have seen in steroids in the last 5 or 6 years. We used to just throw steroids around for everything, but if we look at the data for long-term accumulation, we're seeing risks of osteoporosis, cataracts, heart disease, kidney disease. It's just exponential. It just stacks up the more that you've had. And that can occur with 1 gram of steroid over 8 years, which is 4 causes that you might treat for asthma.
It's interesting to hear you talk about esophageal tone, of muscle tone, because we had a guest on, Dr. Pran Yoganathan, talk about reflux being a reflection of diaphragmatic sarcopenia.
Okay.
And I thought, wow, interesting, particularly when coming back to the breathing. If we're shallow breathing, mouth breathing, we're not engaging our diaphragm. There's another factor on top of all the foods and everything we're doing.
That might tighten it up and close that valve. Going back, I'm seeing what we're talking about as a very tangled Gordian knot, and one relates into the other.
I think it's called the human body.
It is, yeah. We're mixed physiology, and there's not one thing. Again, that's an exciting part of unraveling and trying to explain it. But yeah, all things are not linear, as you know. The esophagus normally should have a pH less than 4, and when we see reflux up there, it's indicative of a condition at level. People say, let's treat that. But we actually have published something about 16 months ago, where we actually looked at baby foods. And we found half of these pouch foods had a pH less than 4.
Wow.
Babies are swallowing foods that will have a pH which is known to injure the epithelium, and they're eating this stuff. Fortunately, I think the esophagus below once you get into the esophagus, it does actually have bicarbonate glands, which can help neutralize acid, but that remains a sort of underexplored area of possible injury. And my take-home message is these pouch foods don't encourage chewing, they don't encourage the development of the jaw, and we're seeing kids get small jaws from not chewing. We're also seeing underdevelopment of the jaw from mouth breathing as well. And we're seeing people in their 20s with sleep apnea because they've got their tongues too big for their jaw. With reflux as well, when you give a proton pump inhibitor or an antacid of any form, they stop the acid. They do not stop pepsin. Now, pepsin is a digestive enzyme, kind of like you might put papaya, like your meat tenderizer. It's an enzyme that digests. And that comes up with reflux to the throat, to the tonsils, to the mouth, the teeth, that's found in the middle ear, the sinuses. So that is still there. And it can stick in the tonsils and digest away and cause inflammation. So that doesn't degrade. And a lovely study was done in 2017, which showed a Mediterranean diet, which is 90% plant-based, more fish, your sort of blue zone type lifestyle. And because stress can be a factor in gastric motility as well. But in this study, they looked at diet and gargling alkaline water. So pepsin doesn't degrade unless the pH is about 8. So gargling a bit of alkaline water that you get at Woolworths or Coles can degrade pepsin and becomes less of an issue. And they showed that was as effective in laryngopharyngeal reflux, where people get heartburn up and bottom in the back of their throat, as a proton pump inhibitor. Far more natural, and I'm keen for that as a treatment as a replacement. If people are getting lower esophageal heartburn, that needs to be monitored and kept in check. I don't ever want to cause a case of cancer with saying, look, I'm not that keen on PPIs, but with any medicine, you've got to look hard. Do I need this medicine? Can I do other things? Can I change the amount of coffee, the stress I have in my life, the things that are making my body want to turn acid on?
There's also, I mean, we've explored also on the program recently silent reflux.
Yes.
And paresthesis of the laryngeal muscles, going back to infections that could have gone on years and years ago. And that's a whole other ball game as well, isn't it? I mean, and as the name implies, often undiagnosed.
Yes, reflux can increase sensitivity of the larynx, and up to, I think, report up to 30% of patients with asthma don't actually have asthma. And as you're talking about the episodic paralysis of the vocal cords, which is called intermittent laryngeal obstruction or vocal cord dysfunction, goes back to about 1983, the first description of that, where it was actually 5 women where they had reports of getting bouts of sudden spasm of the voice and difficulty breathing. And the thing that helps us differentiate that from asthma is that patients with vocal cord dysfunction or ILO will get this come on suddenly, whereas asthma can build up a little bit. It doesn't respond to Ventolin. Tightness is here rather than the chest. Difficulty is breathing in rather than out. And 40% of patients with asthma can have an aspect of vocal cord dysfunction. And the more we use a bronchodilator, we can actually relax smooth muscles in our lungs, but also our lower esophageal sphincter. So when you've got asthma, your diaphragms are pushed down and acid spills up. And if you've got VCD, you're creating a suction pressure and you're sucking acid up. So our treatment of that is the fact that if it goes intermittently, it usually means there's nothing wrong structurally. Speech therapists and ENT surgeons can have a look down with a flexible scope and have a look at the larynx. The treatment of it, and you may get patients in the chair in dental surgery where strong smells or reflux from lying down can actually induce. And the trick with that is to get the patient to relax, glass of water, drop the shoulders, and hands the diaphragm to focus on breathing, and go sip, sip, sip. 3 sips in a second. Sip, 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 sip. And usually 5 to 7 breaths, that disappears. Ventolin doesn't work. It doesn't help that condition. So it's simple breathing exercises. If people want to have a look at that, they can look at VCD and ATS, the American Thoracic Society. They've got a good 2-page information sheet. So it's a very easy thing to get.
And the condition, again, for our listener?
It's called intermittent laryngeal obstruction or vocal cord dysfunction. It actually has the unfortunate name, which has been attributed to it as globus hystericus, which means a hysterical feeling of something stuck in the throat, because it really does feel like something is there. I've had patients come in with this, with their will sorted out, thinking they're going to be dying from it. Usually what happens if they do collapse from it, they relax and start breathing again. And the visualization that I do when I'm explaining this to people is, think of your airways like a wet rubber tube, like a bicycle tire. It's gone stuck together. If you try and do a big, hard breath through it, it's going to be hard. But if you do little 3 sips a second, you'll get enough air so you won't have air hunger. Then breathe out, and you can breathe it away. Practice it so that you can actually deal with it should the emergency come.
Wow, that's so cool. I'm and you talk about a vasodilator, bronchodilator. I know that nitric oxide is one of the body's most potent regulators in that way. Is it not?
Yeah, it has definitely smooth muscle relaxing effects as well.
Which we did a program with someone who'd done a PhD. See, Pete, this is my indulgence, Pete. I get to ask people like you questions and that know so much more than I do, and you answer them and I learn more. But he was a PhD in breathing who said something to me that 60% of the body's nitric oxide is produced in the paranasal sinuses only when you breathe through the nose.
Yes, and that is if the sinuses are not blocked. And this is an area where actually they've shown that treatment with medication or treatment with surgery both leads to that NO. And NO's got bacterial effects. It has antivirucidal, fungicidal effects. So it is important in maintaining that tone. Maxillary sinus, ethmoid sinus. It can even be produced in the upper pharyngeal airways. And as far as work of breathing, 20 to 30% of the effort of breathing is through the nose. It's a magical organ, and when it works, fantastic. When it doesn't work, it becomes the centre of the universe. And it warms, filters, humidifies, detects threat, and responds to threat, which is what causes the phenotype of rhinitis, whether it be allergic or there's other common ones and less common forms of rhinitis. Sort of 1 in 5 of the people watching this podcast will have sneezing with sunlight, which is called photic sneezing, for example. It's 18% of the Caucasian population, most common autosomal dominant condition in Caucasians. And
sneezing with sunlight.
Yeah, it's called ADCHU, autosomal dominant compulsive helio-optic outburst syndrome. There's a great Wikipedia summary on it, and it was originally described by Aristotle. So that's probably the oldest reference I have in my repertoire. So 2,500 years ago. So he actually had the condition himself, and he thought it was the sunlight warming up the brain, the humours of the brain. Thomas Bacon, back in the 1600s, English philosopher, worked out that, again, he had it as well. If he walked out into the sunlight with his eyes closed, he didn't get this.
So what is that mechanism again?
It's a photic sneezing. So the light hits the eyes, and the trigeminal nerve has innervation that goes to the eyes, the conjunctiva, but also the nose. So we learnt in medical school, and you did in dentistry school, that we simulate a nerve and there's an axon reflex. There is, but there's also depolarization of those sensory nerves and release of neuropeptides locally. So along that whole area of the trigeminal nerve, you'll get neuropeptides released. So it can hit there, we can pick up the sunlight, and bang, neuropeptides get released, and we can sneeze. And some people are more sensitive to others. The same as smells can rapidly induce migraines as temperature changes, because of the trigeminal nerve goes here, goes back, and also receives information from the meninges, and depolarization of those nerves can release neuropeptides and cause vasodilation and headaches with just a strong smell like a perfume or volatile organic compounds.
Wow, that's fantastic. Chronic pain. We just chatted briefly about it yesterday, and I know it's not but chronic pain is an interesting one. And you were talking to me about that trigeminal nerve and the excitability of that nerve, and can you just share with us a little bit about that again for me? I just thought that was fascinating.
Okay, there's a couple of ways we can go with this. The one, we talked about rhinitis and hypersensitivity of that, and a crossover with a condition called non-allergic rhinitis, where we have sensitivity of the trigeminal nerve, and particularly chemical receptors. We do see an overexpression of a molecule called TRPV1, which is the transient receptor potential valenoid 1 receptor. It's pretty exciting and more cool because David Julius was awarded the Nobel Prize for his discovery of that in 1997, but he got the award October 4th last year. And this is a very important pain receptor, and it's upregulated in patients with allergic rhinitis, or with non-allergic rhinitis. It is upregulated in allergy, it's upregulated in reflux, it's upregulated in asthma, but it's got a twin called TRPA1, which is where a drug called aminoacetafen or paracetamol works, which we didn't know until 2011. So we've been using it all these years. So paracetamol tells that, and that's a cool channel receptor. But it's got a very promiscuous tail, so it picks up a lot of chemicals like volatile organic compounds, acrolein, methylacrolein, protein in smoke. It picks up things like allicin, which is in onion, part of making us cry, wasabi, horseradish, mustard. So while your nose smarts when you have a bit of, get your wasabi hit, you're overstimulating TRPA1 and causing a release of neuropeptides. And that's happening in your nose, even though you've eaten in your mouth, because the trigeminal nerve is at the top roof of your palate. And that's causing that whole androdromic release in your eyes and nose. So that's just showing you how your nerves can get excited from one side and be felt elsewhere. I'm sure everybody can relate to a mustard or wasabi, but it's the same receptor. B1 does have a little bit of that's a hot burning pain for chili. So we use capsaicin patches to fatigue that, but we can also use capsaicin in non-allergic rhinitis. And you were interested to hear all the triggers for non-allergic rhinitis, which can be found in a nice 2009 review by Jonathan Bernstein in the World Allergy Organisation, the characteristics of non-allergic rhinitis. But these are irritant triggers, and many patients with allergy will have them as well, but may not know. And some people can have the exact phenotype as allergy, or have a skin prick test or a blood test, and know you don't have allergy, but it looks exactly the same. And those type of triggers are perfumes, hairspray, fly sprays, deodorants, incense, gardenia, jasmine, mock orange, potpourri, lilies, cold air conditioning, drop in temperatures, often 6 to 8 o'clock at night, 2 o'clock in the morning, frozen food like the supermarket, cigarette smoke, bushfire smells, burning oil smells, cleaning aisles, diesel fumes, nail polish, newspaper print, freshly painted surfaces, chlorine bleaches, glue, soap shops. And we'll see patients like this often with sulfite sensitivity, the 220 to 228 in beer, wine, cider, champagne, dried apricots, sun-dried tomatoes, sausages, pickles, prawns. And on the Cincinnati Irritant Index scale, they also have artificial Christmas tree smell, turpentine, kerosene, sawdust, smells of molds and grasses, which can be irritants and have lots of thiols and lactones, which can irritate these receptors that pick up danger.
Pete, I'm glad I recorded that because I was so impressed when you said that to me yesterday. And I actually, hearing it again now, I just thought, well, how am I ever going to get that on the transcript? I feel we're going to get it on the transcript. That's going to be good.
I did say
yeah, no, but how do we, what's the state of I remember when I was growing up, there used to be these scratch tests, and is that, what's the state of the art of allergy testing in 2022?
Look, the beauty of scratch testing or skin prick testing, we don't scratch. We've got these standardised lancets that pick up a little of the allergen and deliver a very standard 0.2 nanolitres of allergen into the skin. And we use the pretty standardised allergen. So if I had a skin prick test here in Queensland and I did a skin test, it would deliver the same results as somebody doing it in London or New York. So those are relatively standardised, but they have their limitations. Like for somebody with kiwi allergy or latex allergy, a lot of the allergen those are fairly labile. They'll break down, so when we bottle them, they degrade. So that's the beauty of doing a fresh food skin prick test and a prick to prick. So they have great utility. We can do a range of them and get the answers within 15 to 20 minutes. Whereas a blood test, it means drawing blood. The government and Medicare limits it to about 3 tests at once. So if somebody's worried about what might be causing them allergies in the environment, doing 3 tests doesn't really leave a good bit of much as far as opportunity to go and see what the causes are. So they can get repeat blood tests. You can ask for multiple tests multiple times, but it's part of austerity. You can get a private panel which can look at many of these at once, and some of the pathology labs do this in the range of $380 to $500 to look for a wider range, which is important. If allergies interfere with your life, you don't want to be spending $50 a month on antihistamines, which, by the way, only improve rhinitis scores by about 7 to 8%, despite what the TV ads say in spring. You want that because it can affect quality of life. So we do want to know causes.
So apart from, because now you mentioned the blood test, and I remember years ago having a blood test with a panel of 270 different foods, and they came back and they graded. They ended up with 8 foods that graded on a 1 to 4 scale of my level of sensitivity, and that's a good test to be doing.
I'd say no.
Okay, no, that's good. I don't mind hearing that.
The IgG4 testing, we actually have IgG4 as a tolerance antibody, and there is this form of testing which is available in Australia. It remains to be validated in IgE-mediated food allergy, where people get hives and swelling. We tend to make IgG4, and we encourage IgG4. It's a functioning.
So Pete, let me just stop you, because E was immunoglobulin E, and IgG is another immunoglobulin.
Yes.
I know what it was, but just for the sake of my listener, I wanted to be sure they knew what we were
We have
talking about.
tolerance antibodies. Tolerance antibodies include immunoglobulin A and immunoglobulin G4. Both of them are very special in that they don't have tails that activate the immune system, so complement activating tails. So they neutralize foods, and if we don't eat them, they fall off. So you might have the 270 things. You'll see these. You've got good amounts of IgG4. Change your diet, lose it, and next time you eat it, you're going to feel sick because you've lost your IgG4 because your body doesn't see it. And interestingly, IgG4 has this recycling mechanism. It'll go to the mucosa and mop up our antigen or allergens and gets recycled depending on a pH gradient in the duodenum, which is influenced by the pH of the gut. So, and also if the gut's disrupted, we can lose that pH gradient as well. I was very hesitant to use the term leaky gut because it was a term that other people would talk about outside mainstream medicine, but it's been shown that the term increased epithelial permeability,
intestinal permeability, I think.
But nature's using the term leaky gut in lead journals, so that gives some validation and pioneership to people that were saying, "Hey, this doesn't make sense." And we know that the gut is leaking, but we in sort of mainstream are thinking more in that line. We know that stress can affect gut permeability. We know that pollutants can affect gut permeability. Something that they said, microplastics, these forever chemicals that we're seeing with carpet cleaners, for example. Our body doesn't know how to get rid of them. You talked about the importance of the nose. The nose will make 500 mils to 2 litres of mucus a day, which ends up in the stomach. But what's in there is the trapped environmental irritants and pollutants, so diesel exhaust particles, which we know irritate that. So, and getting out in the environment has been shown to be healthy nature. So we sample that microbiome for both for our lungs and for our gut.
This may seem like a really basic question, but I'm going to ask it anyway. What's the difference between an allergy and an autoimmune condition? Or is an allergy an autoimmune condition?
The allergy, autoimmune is when we attack ourselves. So most allergy is exoimmune. So it's actually something that's outside ourselves. We do have autoimmune allergy with chronic urticaria where we get hives and swelling, angioedema. And that's often associated, well, not often, about 18 to 22%, I think it's estimated, where people have an IgG attack to their thyroid. And there's one of the little organelles inside cells are called peroxisomes. And that's one that we make a lot of antibodies in autoimmune thyroid disease. We make many patients who get chronic spontaneous urticaria decide that the IgE response is going to join the party, and they make IgE responses to peroxisomes. Another common site is that we make IgE to in chronic spontaneous urticaria is interleukin-24, which is a cytokine we often see in high concentrations at the base of the epithelium, bottom of the skin there, and that seems to have a role in melanocyte functioning and regulation of those cells. So it's a target, the body attacks it, and we will end up getting hives and swelling because of our body making a mistake and attacking ourselves.
And when it comes to treatment, apart from avoidance, I guess that's the best. Is that the best treatment?
With any disease, Ron, doing
the
detective work. If there's a fire, stop chucking fuel on it. Mate.
But some people are even allergic to what they would consider to be healthy foods.
Yes, and again, let's go back to the whole body story that I'm sure many of the guests have resonated and get your healthy sleep, get your good nutrition, make sure you're not micronutrient deficient. We haven't had a volcano in Australia for 20 million years, so some of those micronutrients are just not in our food sources, and the way that we eat it, even if we're eating healthy, it can be an issue. Make sure your body knows it's alive, that we're exercising make sure, because the danger receptors go up if we don't exercise. It thinks you're in danger. The body tries and helps ourselves. Make sure your headspace is right. And also, as you're saying, breathing. The nose, getting back to the nose, it warms, filters, humidifies. It's spectacular. It'll take 40-degree temperature or 5-degree temperature and turn it back to 31 to 32 degrees at the back of the nasopharynx to enter the lungs in this nice, comfortable manner. It will end up being 90% humidified. So, and it will have these chemoreceptors that pick up chemicals and danger. And if there's something that irritates it, whether it be an irritant or an allergen, it's got responses that will make mucus to trap that, to sneeze it out till you get away from it or irritate you. And when things go wrong, yes, that's when we have symptomatic disease. As you say, avoid exposure. Our medicines are Band-Aids, and my job is to get the people the best Band-Aids to work out what to avoid. And we do have the luxury of, in allergy, of identifying what people are allergic to, and we have been doing immunotherapy for more than 110 years. Groups in St Mary's were doing this in around 1910, 1911, and giving people injections of pollens that they collected in under the skin, and without all the danger molecules in the epithelium saying, hey, there's a problem here. The body saw it as something that they was part of itself, and would make these protective antibodies, particularly, as I've said, IgG4, which is quite soluble. It would move to mucosal surfaces, and when you breathe it in, it would mop it up, kind of like a molecular sponge. Some would get through to cause symptoms, but we see in 2022 using immunotherapy as a very good treatment. It's sort of the gold standard of treatment for somebody with allergic disease, and we'll most commonly do that for dust mites and grasses, but also animal allergies as well.
And with a good degree of success with that?
The success rate, if you pick the right patients, 85% patients getting a really good response, and you know that in the first 6 months of treatment. If we stick them in a room and pulled it through the gas chambers, like the Vienna chambers they're used to test allergies, they can detect the difference at about 8 weeks with people using tissues and the weight of the tissues and people touching their nose. But if you ask people subjectively, it's around that 4 to 6 months that we see that improvement. And the improvements, depending on what the scales you use, 40 to 70% reduction in medication and symptom scores if you've got the right mixture. So good improvements. If we're looking at antihistamines, you're looking at 7 to 8%. If you look at, say, a simple nasal spray like Nasonex, you're looking at 20% improvement. Going to Dimister, you can look at 40 or 50% improvement in symptoms, which is a combination of an antihistamine and a steroid nasal spray. But again, good Band-Aids, and with immunotherapy, if you've reduced the medicines, if you still need them, they work better because you've got less inflammation. So, and we do immunotherapy for 3 to 5 years. I generally get a good result with 3 years, and because they've become so stable now, they used to be in sort of water-based forms, and still are, but in the newer forms, you can get up to top dose in 4 weeks. So we used to be have to build up slowly over 4 months of week.
And it's a continuous treatment over those 3 to 5 years?
Yeah, it's monthly shots at least once we establish top dose. Okay. But many of my patients, I get to top dose between on 1 day or 4 weekly injections will get chopped to top dose. And we assess and in the first 6 to 12 months to make sure that's working well for them. And if it's not, we want to work out why. And if all's going well, we let them do it for 3 years and have a trial off it.
Wow. Gee, Pete, we've covered so much territory here. My head is spinning. I'm going to be listening to this again. I know I will, because there's so much that we've talked about. I just wanted to finish up. I wanted to take a step back now, finally, and just ask you this question, because putting aside your role as a doctor, a researcher, a teacher, we're all on a health journey as individuals in this modern world. What do you think the biggest challenge is for people on that journey?
I think we're living in probably a too convenient world. We're too comfortable. It's too convenient to eat clean, too convenient to sit down and watch TV, too convenient to actually live. Many of us get into the trap of existing. And not putting effort into having quality of life. And we do that and think a little bit about what we're doing and why we're doing it. Metacognition is one of those skills that we get, thinking about how we think and what we do as we get older. Getting old sucks, but we should get smarter along the way and enjoy the journey more.
Well, as far as I know, getting older is still the best alternative.
Yes.
And thank you so much for joining us today, Pete. I really appreciate you sharing your wisdom and knowledge with us.
My pleasure. Absolute joy to be here and joy to share that and get a chance to have a chat with you. So thanks very much, Ron, and I hope your listeners enjoyed it.
Thank
Cheers.
you.
Bye.
Well, there is another piece of the puzzle, looking at the body as a holistic thing, which it is, of course. And when we talk about specialists, be they gastroenterologists or respiratory physicians or speech pathologists, cardiologists, we come to realize that we are reminded of the fact that we are dealing with a whole human being. And as Pete alluded to, the world of allergy treatment, if you approach it in the way that he has, and he does, then that is really looking at the whole person. It's the only way to interact. It's the only way to identify what is predisposing an individual to a problem, what those problems might be, and importantly, how to build resilience back in to an individual. And we come back to the 5-pillar model of sleep, breathe, nourish, move, and think. It's not rocket science. As the world we live in becomes more complicated, I truly believe the solutions are remarkably simple and accessible and cheap and effective. So this was just a wonderful conversation, which I've been looking forward to for some time. Check out the transcript. There's a lot in this one that you will want to read, and we'll go through that very carefully. I hope this finds you well. Until next time, this is Dr. Ron. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.